Good afternoon, everybody. Thank you so much for joining us tonight. Thank you very much for coming. My name is Reza and I work as a coordinator of programs and services and development at Westman Chapter, Benign, Manitoba. And I'm very excited to see you today. We are here because we have a very special guest with us tonight, Dr. Reza Vosoughi, and he's going to provide us with an education session about MS. Let me say a couple of words about our special guest tonight. Dr. Reza Vosoughi is a Royal College Board certified neurologist and multiple sclerosis specialist practicing in Health Sciences Center, Winnipeg, Manitoba. He got his medical degree and the specialty degree from Iran, and did his fellowship in multiple sclerosis and demyelinating disorders in Ottawa. He is Associate Professor of Neurology in University of Manitoba and also the Adult Neurology Residency Program Director. And in a couple of minutes, we're going to listen to his presentation. Let me also add that here with us tonight, our director from head office in Winnipeg, Daryl Hominuk. So we're very glad to see him here with us today, and I hope you will find this education session very informative. So please help me to welcome Dr. Reza Vosoughi.
Good evening, everyone. Thank you for the kind introduction. When I chose this topic, I didn't know it will create so much enthusiasm, and people don't know what I'm going to talk about. And in a short while, I'll let you know. But before that, I would like to thank MS Society of Canada for their invitation. I really appreciate it. This is a platform that I will be able to talk to patients and hopefully be able to share something about MS with them, something that it's worth their time coming here, and basically to provide some teaching about MS in return to the teachings that I get from them on a daily basis. You know, teaching and learning is a lifelong journey. I learn every day from my patients, lessons for courage, humanity, patience, and all the good things. So I'm hoping that the hour that you're spending here to listen to me is worth the time. This is my disclosure. As you see, I've received some support from pharma companies and for the time that I dedicated to them, but this is the major disclosure. I got majority of the material of this talk from Dr. Google. So objectives of this talk it's divided into three parts. The first part is to learn a little bit about history of MS, and it's a global epidemiology, worldwide epidemiology, and and a little bit about natural history of MS. The second part of the talk is the meat of this talk, and these are basically my messages and the things that I have seen in my practice interfering with optimal care. And it might not necessarily apply to many of you. It might be controversial. Some of them are not facts. They're my opinions, but it's a fact that it is my opinion. Anyways, and I'm hoping that this I can deliver the message. And the third part, as I was the primary investigator for the controversial Ccsvi trial in Manitoba, I just want to talk a little bit about it and the journey that we had and the lessons that we learned. The second part of the talk I have divided into 15 bullets or 15 numbered messages, and hopefully we'll review it together. This talk is not about how to distinguish reliable versus unreliable sites in Google, and this has been the impression of many people who guessed what I'm going to talk about. If you have any questions regarding MS, your to-go site is the website of MS Society of Canada. As a person who've been living in Manitoba, people really wonder why, what I think about living here. And I just simplify it in two sentences. One important thing to say is that Manitobans are great people. I'm privileged to be totally serious, came from the heart. Manitobans are great people. I'm privileged to be here, and I'm telling to many of them that maybe 50 years down the road that we become all paranoid. People here will change, but this is a good time in Manitoba and to live in Manitoba. The rest doesn't matter. Everybody wants to complain about potholes, they can feel free to do that. A little bit about history of MS. Okay. A little bit about history of MS. The scientist who really studied MS in depth basically saw the patients, monitored them throughout their life, and after their passing did autopsy on them was John Martin Charcot, and he's the one who has the first accurate description of this disease, and it was in 1800th century. And if you look at the left-hand side, this is his original drawing, and he demonstrated the gray area, which are the plaques of MS in different part of the brain and brainstem, and this is and spinal cord, and this is exactly what we see in our MRIs. But in fact, the first description of the disease was in 14th century, but it was Charcot who made the connection and defined this disease and tried to explore it further. Since then, a lot has happened. We know more about this disease than we ever know, although with every piece of information that has been added, thousands of questions have been added as well. We know about the role of immune system in damaging the brain and the spinal cord, which is more prominent at the early stages of the most common form of the disease called relapsing remitting MS. We have learned that MS is not only a disease of myelin. As you know, myelin is the insulation, fatty insulation around the nerves that is the primary target of the immune system, but we also learned that this is a disease that affects neurons as well. So in our medical jargon, it's not only demyelinating, but also degenerative, and that's why people progress and accumulate disability and things get worse because neurons die sooner than expected in the brain and spinal cord. We have focused on determinants of quality of life in affected individuals. As you will see, there are many patients that we cannot change their disease course, but we have been able to improve their life expectancy and quality of life by focusing on determinants of quality of life. And we have made a lot of progress in treatment of relapsing remitting multiple sclerosis, which is still far from ideal. But we're beginning to understand and treat progressive MS, and these two diseases are really completely different. There's a long way to go, though. Prevalence means the number of people who live in the society. Incidence means number of new cases that are recognized every year. So what has happened to multiple sclerosis prevalence in the past few years? There is Multiple Sclerosis International Federation that has published Atlas of MS, which is a comprehensive atlas that they published with World Health Organization, and it has all the information that you want. And if you have time, please go on the web and try to find this. It gives you a lot of information. They ran their first survey in 2008, collected the data, and they did a second survey in 2012 and 2013. And added it to the 2008 data. In 2008, there were 2.1 million people affected with multiple sclerosis, which brings the prevalence, as I said, the number of people who live in the society with this disease, to 30 per 100,000. This is average, global. In 2013, the same survey showed that 200,000 patients are added. So there are 2.3 million. And the prevalence over a span of 5 years has jumped from 30 to 33 in 100,000. So the numbers are increasing. This is what you find, and this is a color-coded map. If you move your cursor and put it on different countries, it gives you the number. As you see, some of them are pale, means we don't have information about them, or yellow, and as the prevalence increases, the color becomes richer and richer, and look at the purple one, and where the purple is. This is a diagram that shows Canada has the highest number in the world, 291 per 100,000. And this is the number from 2012, 2013. It might be more now. And after that, you see a whole bunch of European countries, and United States, which is closer to the equatorial area, stands at 135. So hopefully with the presidency of Donald Trump, this number does not increase there because of increased level of stress. Anyways, survey, the last official survey that we have from Canada is 2010, 2011. At that point, 100,000 Canadians were living with MS and 93,500 living in private households, close to 4,000 living in long-term institution, and the prevalence for men is estimated 159 over 100,000. You remember the global was 33. And for women, 418 per 100,000, which is astronomical. For every man affected with MS, we have 2 to 3 women affected, so it's a disease of women. And among the household population, the average age of diagnosis is between 20 and 50, and almost 2/3 of them stated that MS affected their lives at least moderately. So it's not a trivial disease for individuals, their family, and the society. This study was done by Dr. Benign Ms from University of Calgary, and he determined prevalence in different parts of the Canada. It might have changed, but as you see, prairies and Atlantic Canada, they're rivaling each other, highest number. We are one of the highest number in the world. So we know that numbers are increasing over time, and this happened mostly in women. Part of the increasing number that I will explain later is because the numbers, the incidence is increasing in many countries, so there are more new cases are being recognized. But part of the increase in numbers because MS patients live longer with the current care. So if you look at this graph, on the horizontal bar you see the years, and on the left-hand side you see female to male ratio. So as it steeps up, it means that the number of women to men is increasing over time. Study recently published from Ontario. We don't have similar data in Manitoba yet. Hopefully we'll have it soon. And this study determined prevalence, again, number of people living in our society of MS in different age groups and in men and women. And this is happening to prevalence in female, which is the yellow line, and this is what's happening in men. So women numbers are increasing. Same study estimated the incidence and the number of new cases, and it seems that, at least in Ontario, the number of new cases, on the horizontal bar you see the years. Every year it seems that the number has been steady, except 2010 that you see a peak in number in both men and women and men. So the major driver of the increasing numbers is the fact that the patients are living longer, and that's great. Incidence of MS in Denmark is increasing. Denmark is one of the countries that have very good epidemiologic data. On the left-hand side, you see the numbers for men. You see, as from the left to right, you move forward in time, and you see that for both men and women, numbers are increasing, but it's increasing mostly in higher age group, and in women, again, it is more remarkable. What causes MS? That is $1 million question. Nobody has the answer to it. But we know that multiple lines of evidence point towards the immune system in causing damage to the brain and the spinal cord. And in fact, available treatments, disease-modifying treatments, that's shown some proven efficacy, they will do it through the modulation or suppression of the immune system. But we don't know the exact cause. We don't know what makes the immune system crazy. We know that there are risk factors for MS. The risk factors of MS are divided into genetic risk factors, environmental risk factors, and lifestyle-related risk factors. Genetic risk factors, more than 150 genes have been known to predispose people to multiple sclerosis, and these genes are mostly seen in Caucasian, as opposed to First Nations that they are essentially resistant to this disease, but they have their tendency for other diseases. There are some environmental factors, and I will talk about vitamin D. You know, vitamin D is the only vitamin that we get our supply from the sun, and we produce it under our skin. This is the only vitamin that we don't rely on ingesting it. Vitamin D deficiency is known to be associated with multiple sclerosis, but studies have shown that if you supply treatment of patients with multiple sclerosis with vitamin D, especially in vitamin D deficient, it's good for their bones, but it seems that it does not do a lot for their disease. So it's hypothesized that the vitamin D deficiency in early life is doing something to your immune system that later present itself as multiple sclerosis, and by the time that the MS presented, providing vitamin D is not something very effective. There is another virus called Epstein-Barr virus. It's the same virus that gives infectious mono or kissing disease. Most of the adult population are prone to this virus, 90% of them, and in MS patients this number is 100%. So it seems that this virus is also related. And smoking increased the risk of MS, and smoking increased the risk of MS disease activity. Just one word about vitamin D. As you know, the UV, ultraviolet B, is the part of the sun rays that help us to produce vitamin D. And the world is divided into 3 zones. Zone 1, that you see in the middle, is the zone that people who live in those areas have sufficient vitamin D production throughout the year. Zone 2 is the area that 1 or more than 1 month a year people do not receive enough supply of vitamin D from the sun. And zone 3 is the zone that all year round the supply of vitamin D by the sun is not enough. And guess where we are? Part of the studies about MS that I really like, and I'm hoping that down the road it will shine some light to the underlying cause of this mysterious disease, is the migration studies. And the gentleman that I will show you in the next picture, his name is John Kurtzke. He spent 60 years of his life chasing this disease and to find what's going on. And one of the interesting things that he found is that if you move from a low-risk area to a high-risk area, if this move happens before age of 15, you will acquire the risk of the population that you're going to. So if you're coming from an African country and you move to Canada, which is high risk, if your year of move is before you hit age 15 or 16, you will have the risk of Canadians. And if it happens after the age of 15 and 16, you will retain the risk of your origin. So it seems that something happens to our immune system early in our life. This is the gentleman, John Kurtzke. He was a pioneer in this field. And and he's the same person who designed this disability scale, EDSS, that many of you are familiar with, and it is still being used in all of the studies that evaluate the role of treatments in MS. And the numbers that you need to keep in mind is that if your EDSS score is 0, it means that you have no neurological disability. In this room, probably nobody is 0, because I'm standing at 2. And if you get to 6, it means that you need unilateral assistance for walking, or a cane. 6.5 is walker, and so on and so forth. So this gentleman, after 60 years of studying this disease, he published a beautiful paper in Brain, and they published it as an occasional paper, and it was his opinion. And his opinion is that probably everything starts with an intestinal infection like gastroenteritis. And it deranges your gut immune system, and that's the beginning point of the disease. He called it multiple sclerosis affection. And I'm still thinking it's a very valid point, and it's being studied vigorously, and I'm hoping that in the years that I can still think and practice something will some illumination comes through his vision. Search is underway for the cause of MS, but again, I emphasize the cause is unknown, and that's why the current treatments that we have, although they're effective, they're not ideal. And why they're not ideal? Imagine this is your brain, and this is your immune system. The immune system wants to destroy the brain. We don't know why he's not behaving. We give the immune system an injection, tranquilize the immune system, and part of the problem solved, although the root of the problem is not solved. It is not solved. That is why with the current treatments, we see the consequences. When you modify the immune system, you're putting people at more risk of infections and opportunistic infections. PML and JC virus is known to many of you. And also, we need our immune system to clear our cancer cells that we form basically on a daily basis. Anyways, we do not know what triggers the immune system. A little bit about natural history of multiple sclerosis, and you need this piece of information to, when I get to the points that I want to deliver 15 messages to you. The clinical patterns of MS, the most common form of MS is relapsing remitting MS. It consists of 85 to 90% of MS patients. These are the group of people who are younger. Median age of onset is 30. This is the one that is more common in female. And if you put time on the horizontal bar and disability on vertical bar, you see with each relapse, the disability comes up, and with improvement of that relapse, the disability goes down. And over time, relapses keep happening again. The relapse might result in complete or incomplete recovery. That's why it's important to prevent the relapses. The second form of MS is called primary progressive. This is a disease that is characterized by progression from onset. The legs become weaker and weaker without any periods of improvement. This disease might plateau for years, and in fact, in the recent classification of MS, when somebody is classified as progressive MS, we should specify whether the disease is progressing or not. This consists almost 10% of MS cases, and these are the ones who are older, and male to female ratio is 1:1, equal involvement of male and female, and this is how you see they will do over time. Secondary progressive multiple sclerosis are the ones that after having relapsing remitting disease for a while, the disease converts into the progression, and it seems that up to 90% of people who are relapsing remitting MS will eventually convert to secondary progressive. The timeline for transition in the natural history studies is different, but you can say on an average this happened between 10 and 25 years. And this is how it looks like. Some relapses, some improvement, then subsequent worsening. There's another form of MS which is called benign MS, and it would have been great if we knew the secret to this disease. This is a relapsing remitting form of MS that after a few relapses, the disease goes into quiescence, doesn't show any activity, doesn't become progressive, and these are the ones that have good outcome. And we don't know how to distinguish them from the other ones. In a study from UBC, Helen Tremblay studies these timelines that I spoke to you about, and she studied the time people start using cane from either the disease onset or from the time of birth. And in relapsing remitting MS cases, from the diagnosis till reaching that stage is around 30 years. In primary progressive is around 13 years. And if you look at their age, relapsing remitting people get to that stage at the age of 61, and primary progressive get there at the age of 57. Just one slide versus about relapse and pseudo-relapse. This is important for you to know. And relapses are also called flare-ups or attacks or exacerbations or incidents, are neurological symptoms that are caused by new disease activity, new inflammation, new immune system attack to the brain and spinal cord. They last days to weeks and will have partial or complete recovery. By definition, symptoms should last 24 hours. And the reason that I put this in, so for every new onset tingling and anything, do not panic, please. But we also have pseudo-relapses, means recurrence of the previous symptoms that you experienced with some intercurrent infections, some psychological stress, and this does not mean that the disease is active or is doing something bad. So it's important that in cases that we suspect, contact the MS clinic, and it's worth to the patient to be examined in a timely way and see if there's any infection going on, especially the urinary tract infection. Now I'm getting to the second part of my talk, and these are 15 points that I want to share with you. Again, some of them are controversial. Again, we might disagree on some of these, but this is my from the heart message to the patients. You know we're not perfect. You know we know our knowledge is limited. And hopefully as things move forward, we know more and more about this disease. This is message number one. Remember that you're aging regardless of whether you have MS or not. You will not have a good aging if you don't take good care of your body. Comorbidities or comorbid conditions or other conditions that happen to your body should be controlled, and I will provide evidence for that. And remember, exercise is a key factor to feeling healthy, having good energy, self-esteem, and even positive attitude. Comorbidities are, by definition, are the total burden of the illnesses other than the disease of interest. So comorbidity means like having a person with MS and diabetes. As you know, in general population, comorbidities are common and they increase with age. Dr. Mary, who is known to many of you, she's a world-known researcher who has her focus on comorbidities, and she has been able to provide very important information about these things. So, again, emphasizing comorbidities are common in MS at the time of a diagnosis and increases with age. And if you have comorbidities, the number of comorbidities that you have, as those numbers increase at the time of diagnosis, you will have more disability. And as those numbers increase over time, the speed of progression of your MS is also getting worse. It increases the hospitalization, it affects the quality of life or treatment use. Comorbidities can be psychiatric, like depression, and up to 50% we see it in MS, which is 3 times more common than the general population, and anxiety, which is up to 35%. And comorbidities can be physical. The most common ones are high blood pressure and high cholesterol, easy to control. The rest are less common. If you look at this graph, on the left-hand side, to simplify it, it's the disability that the patient feels, and on the right-hand side, number of comorbidities that they have beside MS. 0 means the person who is having MS only, so only 10% of them feel disabled. And as the number of comorbidities increases, that number increases, so it's best to control them. And this graph, to just simply explain it to you, the faster the line goes down, the faster disability happens. And the blue line are people who don't have high blood pressure, diabetes, cholesterol, smoking, and the red line are the ones who have 1 or more of these. And the difference is 6 years. These two, whatever level of disability you will reach with your MS, if you have all the other stuff added, you will go down faster by 6 years. Even control of high cholesterol can affect your MS disease activity. In the study that they did, they showed that HDL, which is the good cholesterol, if it is high, the chance of activity in the brain MRI goes down. And if triglycerides or LDL is higher, the likelihood of having activity in your MRI increases. So it's important to do things that you can do to prevent and treat some of these comorbidities. Stop smoking and don't think it is irrelevant. Healthy diet, exercise, and weight control. And remember, walking is not an exercise. Casual walking is not considered an exercise. Exercise is something that either challenges your heart or your muscles and you sweat. A little bit about fatigue and MS. Fatigue is a very important symptom about multiple sclerosis. This is the most frequent symptoms reported by patients with MS. Affects 50 to 80%. Can have significant impact on mental health, quality of life, productivity. And by some of our patients, it is described as the most disabling aspect of the disease. We have multiple interventions to treat the fatigue, but the Cochrane Library is composed of a group of independent researchers that do systematic reviews, and they studied multiple studies, systematically reviewed multiple studies about exercise and fatigue in MS, and they showed without doubt that no matter what type of exercise you're involved in, your level of energy is better. So it's the first step to manage your fatigue is to get yourself into a regular exercise program that is appropriate for your level of function. Rule number 2, it's important because I hear it from people. Your doctor are on your side. They're not on the side of the pharmaceutical company. You have to trust your doctor. But be abreast of the news and arm yourself with knowledge. The outcome of a knowledgeable patient is better than the person who doesn't know. Look at diabetes. If you know how you treat your diabetes, you will have a good life. If you don't know, it will cost you your eyes, your kidneys, your limbs, whatever. These are the benefits of the knowledge, and I emphasize it because of the last part of the talk about the Ccsvi. First of all, you can monitor your disease better so you know when things are not going in the right direction. If you know your disease well, you will not panic for every unnecessary reason, being anxious and destroying your quality of life on a daily basis. You will pay attention to important but subtle changes in your disease that warrant a change in your therapy. You will avoid polypharmacy, and you will avoid continued use of unnecessary medication. You are familiar with this pattern. We add medication and we add another one and we add another one, and we never, many of us never check, okay, if the first medication that we started, is it still necessary to be on board? So if you question these, you will avoid polypharmacy, which is attached to a not good outcome. You'll not be fooled by charlatans. They only want your money. So now treatment, you still can get treatment for Ccsvi and stem cell therapy in many countries in the world. You will learn to question things. It's important to question everything. And you will not hesitate to get your medical advice from somebody like Jenny McCarthy, who believes autism is caused by vaccination. And now the number of kids who are not vaccinated in some of the US cities is 20%, which is unbelievable. You can prevent potential mistakes in your treatment. We are humans, we make mistakes. If we have somebody who is controlling us well, the numbers of mistakes will be minimized. And unfortunately, the mistakes that we make as physicians does not have good outcome. Knowledgeable people can influence the healthcare research and improve outcome for future generation. It is incumbent upon us to do something for the future generation. You have all seen the influence of social media in the Ccsvi propaganda. It cost the taxpayers, Canadians, a lot of money. Some went and received treatment and got stent and they died. I'll talk about it later. Number 3, and this is my opinion, one of the major tolls of MS is on psychological health of my patients, because patients lose the ability to predict the future because of this disease. I say it is because of the limbo. You know, they feel to be in a limbo, and it's really not good. And the more you have knowledge about this disease, the more you can limit this limbo effect. And this term does not exist, it's the term that I use. Many of the patients even try to ignore the disease from the beginning because they cannot tolerate the anxiety that comes with this disease of unpredictable future. MS is a very tricky disease and has always been. Remember, the consequences of the decision that you make now will appear in decades. So you cannot say whether the decision that you made is good or bad in 3 to 5 years. First of all, your symptoms do not tell you where the disease will go. If you're very tired, you might still be walking 50 years down the road. And if you're feeling completely good at all, your disease might still be silently active. Relapsing remitting disease can be unpredictable, as you can imagine. And progressive disease, sometimes it plateaus on its own. And your disease can actively and silently cause damage to the brain, although you feel completely well. So you see all of these, and you know why this disease is tricky. And relapses improve spontaneously. Everybody can claim that they invented something that treated the relapse. There are different interventions that can make you feel better, but it does not mean that you will do better down the road. These interventions, whatever they are, is good. Do it, but remember, it does not replace advices of your doctor about your treatment. You want to know why MS is tricky? Compare it with cancer. Imagine, God forbid, somebody gets a breast cancer. They go to doctor, get the diagnosis, undergo surgery, chemo, radiation, and never try to discover treatment on their own. Why? Because whatever decision you make, the consequences of it will be in your face in a few months. But in MS, that time span is decades. The fluctuation of MS symptoms and long delay to face the consequences persuades everyone to go and discover a new treatment for MS. It's important to trust scientists only. Number 5 is in line with number 4. Do not try to discover MS treatment yourself. Your chance of success is not high. Do whatever it makes you feel better. I have no objections, but if your doctor offered another treatment, you have to do it as well. This mysterious disease treatment would have been found years ago if the solution was simply a B12 or a gluten-free diet. Number 6, relapsing remitting MS and progressive MS, either primary or secondary, are completely different entities. We are way behind in diagnosing, in finding a treatment for progressive MS. In fact, the first treatment that showed a measurable but moderate small benefit has been approved just recently, but the first medication for relapsing remitting MS was approved in 1993. You can imagine there is a 25 years gap between the science for these two forms of MS. Remember that your MS doctor is a fan of disease-modifying treatment in appropriate patients. And they are always happy when they can help you. They suffer when they cannot do something for you. They suffer when you suffer, and they feel joy when they help you. And that's the one that gives them energy to go through life. Why they're a fan of disease-modifying treatments? Because these are the only things that has shown to work. They prevent relapses. Remember, you accumulate disability with relapses. They control silent inflammation in the brain and damage to the brain that can be seen in the MRI, which is another very important aspect, and that's why we do regular MRI follow-ups for our patients, and they might be able to change the disease course. No other intervention has consistently shown benefit in MS patients like Ccsvi liberation therapy, but these medications did. Again, there's a big but here. These medications do not have the same effect when they started late in the disease course. As I told you, 15% of MS patients are benign. They never develop disability. And those are the ones that we cannot distinguish at the very beginning. So you might be receiving a treatment with one of these disease-modifying treatment, and simply it's not the treatment that controls your disease, it's your disease that is a good disease. And different patients with different MS severity will have different responses to treatment. Some, unfortunately, do not respond at all. You remember, that is the problem. If we knew what made the immune system angry, we would have been in a better shape. There is one slide recently presented in European ECTRIMS, which is our biggest global meeting, European Committee for Treatment and Research in Multiple Sclerosis. I just put this slide here just for your information, and they studied 2,200 patients, 69% female, and with different variable follow-ups, but the accumulating follow-up was 15,000 patients here, with mean age of onset of 32, average EDSS disability, mild disability of 2.8, and they compared people who were on some MS disease-modifying treatment and some people and the others who were not. Variable follow-up, and it showed that when you are exposed to these medications, your accumulation of disability is less. Sometimes your disability improves, and you have less relapses. And it's concluded that continued MS therapies benefit patients, and this is in line with our experience. The face of this disease has changed a lot over years. If you would have had this disease in 1960s that there were no treatment, your outcome was not as good as what you have now. And as you saw, the number of MS cases are increasing, and one of the main reasons for that is that people, they live longer. We're going to number 8. I hope you're not tired from this talk. Remember, treatment with this disease-modifying therapies is counterintuitive. You treat yourself and accept the risks of those treatments to feel no different, and some people cannot digest it. This is my opinion. Golden years of treatment of relapsing remitting MS are early years. Don't miss this opportunity. Hopefully, with the change in the medications that we'll have, we can gain access to more effective therapies that will work at all stages of the disease. Number 10, remember, all pharma companies, they believe their product is great and they promote it, right? But it doesn't mean that the product is bad. Remember, approval of medication is a lengthy process. It's a controlled process. In Canada, first Health Canada approved it. Then it goes to another organization called Cadet. Then it comes to the province. They should all agree that this medication is doing something. This is not like vitamins that they can cure everything. It is your doctors that can guide you to find the best treatment for you, and with the increasing number of these medications, it has become so complicated that many of the general neurologists don't feel comfortable to treat MS patients. Remember that without collaboration of the pharma companies, we should have still been treating patients like centuries ago. In fact, this event is sponsored by a pharma company. Pfizer, which is one of the big pharmaceutical companies, is taking out its funding from Alzheimer and Parkinson research. And all of the scientists are concerned that if all of the other companies do the same thing, basically we have got to the end of the treatment of Alzheimer and Parkinson disease. Canadian doctors that I have seen, they all want to do something for the patients. In the unlikely event that you face someone that you felt that they have put interest of the pharma companies ahead of interest of yours, that's where your knowledge can save you. Number 11, these people are not good sources of advice for your MS treatment. Share with them, get their advice, but neighbors, friends, you can't believe it. In Iran MS Congress that I attended, there was a guy who was promoting his cards in the Scientific Congress Natural MS Therapy. And I don't know. Anyways, these people can provide you with advices in their own field of expertise that I, as MS doctors, I cannot, and I'm not qualified. But they cannot talk about, they cannot provide first-hand advice about MS. And remember, as I told you, wrong decisions, good decisions, the outcome you will face it in 20 years. Anyone who says that he or she knows the cure to MS is lying. That's it. Many of our patients, we have seen that because they either thought or they, felt that there is a miraculous treatment available somewhere, and their doctor will disagree with them. They did not even discuss it with their doctor. Remember, receiving a non-approved treatment, investigational treatment, somewhere like Panama with your RSP money is not, without discussing with your doctor, is generally wrong. It's not a good idea. Discuss it with them, and if you still want to do it, do it. Remember, when there is no cure for a disease, somebody who wants to help themselves and do something that there is no enough evidence behind it, many of us, if we get there and we'll put ourselves in their shoes, probably would have done the same. But it's best to hear from different people about what you're getting into. So this is not a good idea. Number 14, there are a group of patients with MS that we can help to change their disease course. And a group that we cannot make any changes to the disease course. In this group, we focus on their symptoms and their quality of life. And do not underestimate the role and power of any of these healthcare professionals how much help they can provide for you, including social worker, occupational therapists, physiotherapists, dietitian, nurses, etc., along with doctors. And this is the last point of this talk. It's important to remain positive and optimistic when facing difficult diseases like MS. Sometimes it is very frustrating, but make sure this does not blind your logics and critical thinking. One of the MS researchers who is very well respected in our community said something that I just read it verbatim. His name is Alistair Compton, he's in UK, and he said clinical charisma and the exploitation of the frightened, vulnerable patients and their relatives litter the historical highways and byways of therapeutic endeavors in multiple sclerosis. It has not been a golden road. And I always remember what he said. Last part of the talk, hopefully you're not tired. This is the Ccsvi story. You know all that it all started with CTV-W5, that a scientist named Paolo Zamboni, who is a vascular surgeon in Italy, who had a wife with multiple sclerosis and wanted to help his wife, came up with a brilliant idea, which I still think it was a brilliant idea, but it did not stand the test of time. He was a vascular surgeon. He was dealing with the peripheral vein insufficiency. You know, people who have peripheral vein insufficiency, blood goes to the leg, doesn't come up. Veins are engorged, rupture, red blood cells that are responsible for the delivery of oxygen to our system, and they have a lot of iron, they ooze into the tissue. And that iron is toxic for the tissue and cause ulcers and ongoing damage and inflammation. And he thought, wait a minute, probably this is the same thing that is happening to MS. Blood goes up, doesn't come down because veins that are draining blood from the brain are narrowed. So the vessels inside the brain engorge, red blood cells ooze out, iron in the tissue, inflammation over and over, and it becomes MS. And in fact, it was a brilliant idea. But before we get a chance to test this idea, and rightfully so, because many of the patients were desperate and frustrated with their limitations and the fact that there's the progress of science is slow in this field. Yeah, this is his theory. Yeah, they're narrowing in the jugular veins, the blood goes up, doesn't come there. So many of the patients who were frustrated started to want that treatment. This picture is from Alberta. Everybody wants the Ccsvi treatment. It is estimated that 3,000 Canadians went and received the treatment. And because veins are loose structures and they were doing angioplasty, basically they put a balloon in it, they dilated it, so they opened the vein. And veins, because they're loose structures and they conform to their neighbor tougher structures, they would collapse again. The same gentleman, Dr. Zamboni, said, oh, it's better to stent them, disregarding the fact that stenting the veins is not like arteries. The blood flow is so slow that blood clots immediately. You know, 2 Canadians died receiving that treatment. This is another rally from Parliament Hill that people want to be unplugged. And this is from Legislature of Manitoba. So, MS Society of Canada, Canadian Institute of Health Researches, and provinces decided to put a few $1 million into the study, which was a reasonable thing to do, but under extreme pressure from social media, and some politicians get themselves involved into these things, which is really not their field of expertise, and I wouldn't take advice from them. The primary center was Vancouver, Dr. Anthony Trabolsi. There are 4 other centers, Montreal, Winnipeg, I was the primary investigator here, and Quebec City. And we calculated that in order to have a robust data, we enrolled 100 patients, and we enrolled 104. The design of the study was great, because one of the biggest thing in MS studies is the placebo effect. You feel good, then you feel good. So people would undergo an ultrasound to see if they have criteria for Ccsvi. And after that, we would send them, each patient, to the angio suite. They put a catheter in your vein, they inject the dye in your vein to see that you actually have this stricture or not. And after that, it is confirmed that the patient has all of the requirement, including the venous stricture. We would knock the patient down, completely anesthetize them, and open an envelope to deliver them the actual treatment or no treatment. And the reason that we would anesthetize them is to don't feel the pressure of inflating a balloon in their neck, because they could have remembered that they felt the pain in the neck and they could have known that they received the actual treatment. We would follow, dividing these group into half and half actual treatment, half no treatment. We would monitor them for a year, then we'll send the same people to the angio suite with a crossover. So the people who receive treatment would receive sham, and the people who receive no treatment or sham would receive the actual treatment and follow them for another year. So the study was double-blinded. It means that neither the patients nor any of the physicians who were involved in the assessment of the patient would know who received what. And sham-controlled means it's important to know, to have another group that they think they received a treatment, and the study was crossover. So the first participants were randomized in 2013, last one in 2016, and we screened 274 patients. Obviously 104 were randomized, 65% female and 62% relapsing, the rest progressive. The first year data has been submitted for publication. In none of the measures, including subjective feelings, patient-related outcome, questionnaires, brain fog, warmth in their legs, disease relapses, disease progression, changes in neurological exam, MRI, there were no difference between the two groups. Again, many of the patients claimed that they received a miraculous response from this treatment. I would say if it is a benign procedure, you can do it, but again, this does not replace your doctor's recommendation. Zamboni himself, who originally had proposed this study, enrolled some patients. I don't remember the number, but it was about around 100 patients. And he did this, again, similar design, randomized clinical trial, and this is his conclusion. Venous percutaneous transluminal angioplasty has been proven to be safe, but largely ineffective technique. The treatment cannot be recommended in MS patients. And CTVW5, they still believe that this works. Now they say, oh, no, it doesn't fix MS, but people with MS get less headaches. The Ccsvi is going around still looking for the disease. Haven't found one. Anyways, 7 o'clock, my talk is done. Thank you for your time. I hope it was worth your time coming here, and I will be happy to take questions. I assume there are a lot.